Okay, everyone, I'd like to welcome you to misophonia treatment and management options. This is for primarily for individuals and their loved ones with misophonia. I'm Tom Dozier. I'm the president of Misophonia Institute. I'm a behaviorist. I'm a behavior scientist. I'm not a psychologist. I'm not a family therapist. I'm a behavior scientist. So here's our outline. We're going to go a little bit quickly over what we had learned in Recognizing Misophonia webinar, and then I'm going to talk about a proposal for what causes misophonia, talk about some of the different management protocols, how to reduce the reflexes, do a number of treatments, and not necessarily in that order. So let's take a look at this just quickly. Here's the publications that I've been involved with. Not going to go through these, but I just want to say that there's a number of publications out there that I'm an author or co-author of, including the book Understanding and Overcoming Misophonia. So in 1997, audiologist Marcia Johnson had a tinnitus clinic, and she noticed some teenagers, typically young girls, being brought to her with these very unusual sensitivity to mouth and nose sounds. She called it selective sound sensitivity syndrome, brought it to the attention of the Astroboffs. They published and gave a name to it of misophonia, meaning hate or dislike the sound. And it was generally considered an audiology phenomenon for probably 15 years, until we had this great article in 2001 when chomp or slurp is a trigger for outrage, and then we started having some non-audiologist studies of misophonia, and I got involved in about 2012. At that time, it was strictly publications about audiologists. We find, this is from a survey that we ran, that misophonia can develop at virtually any age, although it does typically develop more often in childhood, late childhood, 9 to 10. You can see a very nice curve there, but it still continues to develop out here into the 20s, 30s, and 40s. So it can develop at any age. Prevalence of misophonia is not well defined. When I first got started, I found a lot more people with misophonia than I expected. And so as a result, I did a simple survey, buying it on SurveyMonkey, and found that about 15% had similar responses to those who said they had misophonia on the misophonia websites and groups. The Astroboff said it's maybe 3%. That's probably serious misophonia based on what comes in, people that come into their clinic. There was a study in Florida saying that it was more like 20% of their undergraduate students, psychology students, had clinically significant misophonia. And that was repeated in a PhD dissertation by, I think it's Victoria Cash. And the community sample was lower, so 13.5%. They found no difference between men and women in terms of how often they had misophonia, but women tended to have more severe misophonia. And then there's some other studies I won't go into. Auditory triggers. We did this study, and yeah, it has a reason. There's a reason why it deserves to be known as when a chomp or slurp is a trigger for outrage. Mouth sounds were by far the highest, but 96%, but that means 4% did not have mouth sounds for triggers. Then breathing sounds, mechanical sounds, again, all kinds of speech sounds, all kinds of other sounds can happen there. And then visual triggers. Out of the 1,000 or so people that was in the survey, 92% reported at least one visual trigger. So visual triggers are definitely part of misophonia. It can be all kinds of images. And then there's other triggers, feeling vibration, odors, maybe a touch from some person, a certain vibration. And virtually any repeating sight or sound or sensation can be a misophonia trigger. So misophonia is really a multi-sensory response disorder. And the emotions, they're extreme: anger, anxiety, desire to get away, rage, hatred for the person, disgust, fear, sadness, despair, guilt, resentment, all kinds of emotions are the strongest, most noticeable characteristic of misophonia. And a very simple criterion for misophonia is that it's an extreme emotional response with anger, disgust, anxiety, or so forth, to a commonly occurring innocuous stimulus, any kind. And there's also the question, is misophonia caused by genetics or experience? And the answer is really yes, both. There are people who have emotional sensitivity, sensory sensitivity, anxiety, they're strong-willed, they're really in tune to the emotions of others, and we find it runs in my family, it must be genetics. Well, is it experience? Well, some say it's caused by trauma. Well, in some cases, trauma brings it on. Other cases, it's just normal stress in family life. A lot of people have that. It runs in my family. Now, that's an experience. We share family experience. And there's a lot of personal stories. There's a few ones that give us a specific insight to the experience factors that are needed to start misophonia. So it takes both genetics and experience. I want to show this video, and I'm going to show it. I'm just going to go ahead and show it in the kind of jerky frame here. But here's an avalanche, and I want you to think of misophonia as similar to an avalanche. You know, by the way, the snowboarder is fine. He lives to tell about it. I don't know if he was hurt or whatever, but notice all the power and the tumult, and the snow comes raging down the mountain. And notice at the bottom, people start running, trying to get away from it. They're trying to run away from it, and it comes down and it envelops everyone. And then even once the snow stops moving, it's still there. And the cloud of dust takes a while to settle. So let's move on and say, in what way is misophonia like an avalanche? Well, where did it start? You know, we don't see this little invisible slip of the snow up here. It first starts, then gets bigger, and then you get the crashing and the power and all the tumult of the snow coming down the hill. Well, when misophonia is very similar to that, because we focus on, you have misophonia, I do not, so I can't say I understand what you're feeling, but you're focusing on all of this extreme experience that you have after the triggers start. And when we look at this, we know that there's all of this emotion, but we also see that from the research and from clinicians working with individuals, we see that there is what we call the initial physical response. And in order to show you this well, I'm going to switch over and I'm going to put on what we call our fake webcam. And the fake webcam allows us to play another video. And I've got to pull this up. I'm going to play, watch the girl's shoulders jerk. There's a sniffing here. Her shoulders and her foot. And you'll notice that her shoulder jerks and that her foot jerks when she hears the sniffing sound. Now watch this with her foot. Wow, look at that jerk of those muscles in her calves. Throws the toes
just
out.
One last stop and then that'll be the end of it, okay? Okay. Y'all relaxed?
Okay, that is an extreme response. And that response is just like her getting tasered in her calves. And so I'm gonna, if you've seen my video, Misophonia, what is it? I demonstrate misophonia with a rubber band. And it's like, let's do it on this side. Sniff, oh, sniff, oh, sniff, oh. And you're actually physically contacted, you're physically jolted when you hear a trigger. And so with that understanding, trying to get this out into public awareness, Kate Morrison and I did a study where we exposed people to weak triggers. And when they were exposed to weak triggers, everyone, not every time, sometimes they weren't even triggered, but everyone reported a physical sensation, and the most common was in the shoulders and neck, hands and chest, but there was also anywhere in the body, literally from head to toe, and even sexual responses in between. So misophonia has a physical component to it. It has what I call this initial physical reflex, but it also has the emotional reflex. It has the heart rate, the sweating, the muscle tension, and then there's the things that you do to try to get away, the fight or flight, the trying to push back, make a person stop the trigger. All of those things are common with misophonia. Now, what's happening here comes from what we call neuroplasticity. It's been said neurons that fire together wire together. And so essentially the experience that you have with a stimulus and the physical things that are going on in your body and the emotions all become integrated so that when that stimulus happens again, it takes over. You have all of those other responses. Now this starts in infancy, like the first day. In the first day of a baby's life, they're being held, they're being rocked, they're being touched, and mom's going, yeah, yo, you're so beautiful, I love you so much. And so by the end of the day one or maybe day two, if the baby fusses, mom can say, oh, I love you, it's okay, honey. And the lizard brain, this automatic learning system goes, oh, and relaxes. And that's a very good reflex. And that's part of this automatic acquiring of these responses. Now, for me, I have a response when I put my hand out to touch a dog's head. I've had a number of unpleasant events, but at age 21, I reached out to pet my in-law's little dog, and the dog bit me, and my heart goes, oh! And then for years, I go to reach and to put out my hand, and I'm not afraid of dogs. Don't like I have a dog phobia, but when I put my hand out to touch the dog, my heart starts palpitating. Now, the emotional response, those are also a reflex. Dr. Kumar and company did a great study, and we were fortunate to have him present at the 2015 Misophonia Association Convention. And in that, he brought out some not just the basic facts, but some interpretation of them. And one of the things he brought out was this ventromedial prefrontal cortex involvement, with two little spots behind your eyebrows. And those are known to be involved in both regulating the emotions, so it either accelerates or decreases the emotions, and it turns something that's neutral either into a positive response or a negative response. So essentially, this is what we would call a learned or an acquired emotional response, or a conditioned emotional response. Now, the other areas up there in the limbic system that are going crazy, one is the anterior insula, and it does internal and external sensation. And so it gets the feed that I heard, saw, smelt, or experienced a trigger. And it also gets the jolt, whatever physical sensation is there, and it feeds it up to the anterior insula, which then communicates with the VMPFC and then the hippocampus and amygdala, and then all the avalanche takes over. So, but with these VMPFC, for people who don't have misophonia, that's what this shows right here, the VMPFC is actually reducing the emotional response to what would be a trigger for a person with misophonia. But for the person with misophonia, the little old spots going, rage, anger, disgust, it actually accelerates and forces the emotions into your brain. So you're having an emotional reflex. And so even if you decide, I don't want to get upset, sorry, it's a reflex. And with a reflex, it happens to you rather than you choosing to have it happen. So, Dr. Kumar, I'm not going to read all of this, but he said basically that given the role of the VMPFC in learning associations, meaning developing these positive and negative responses, our data is consistent with the view that aberrant associations represented in the MPSC drive the areas involved in emotional processing. So in plain English, misophonia emotions are a conditioned or an acquired emotional response. They develop through experience with triggers, and they're involuntary. So it's not a choice. And then we have the study by Edelstein and company, which showed that there is a physiological distress, that these emotions that you're reporting are real, they're valid, and you're having distress from both the auditory and the visual. This red is the visual line you can see is higher, but because there was only a small number of people, there was statistical overlap between that and the control group. So some personal examples of developing misophonia. A woman I worked with as a girl, she had washed her hair and she was in school, and the boy behind her was claiming he was going to had sniffles and it was going to blow his nose on her clean hair, and she was pulling it out of the way, and she developed a reflex of a sensation on the back of her neck from this experience. Bill was a man that I knew who didn't have any conditions, but he had mockingbirds build their nest outside of his window. Now, isn't that cute? Wouldn't you just think it'd be wonderful to have a little bird nest outside your bedroom window? Not mockingbirds, because the male mockingbird chirps 24 hours a day, marking their territory and looking for their mates at certain times of the year. And so Bill would just be laying there trying to go to sleep and hearing this call of the mockingbird, and it just started to develop a physical response. He would get these chills up his upper arms. And it wasn't just to any mockingbird sound, although there's only one variety in the United States. The recordings of mockingbirds in other parts of the United States wouldn't trigger him. It took specifically the unique calls of the local Northern California mockingbirds. And then John is a really great story. John remembered as a teenager developing misophonia. He had anxiety, and so he'd often have trouble going to sleep. And his brother, he shared a room with his brother, and his brother had allergies. And so he's laying there one night, he's hearing his brother breathe, he's trying to go to sleep, he's having this anxiety. He goes to the couch, goes to sleep on the couch, but after that one night, every time he heard his brother breathe, it triggered him. So that's unusual that a person remembers this, but it only took one night to develop the misophonia. And then we've also seen behaviors that people have that's matched to what they were doing when they developed misophonia. A girl that we call Carla, let's start with Karen. She had asthma, and she would try to breathe, and she'd hunker forward and squint her face and pull for breath. And when she was triggered, it would close off her windpipe and jerk her muscles, and her shoulders would come forward and her face would squint. All the things she was doing when she had asthma as a little girl, when her brother was over there smacking his lips on pancakes. And Carla, she developed the trigger at the dinner table, and she would stand up and yell, "Stop staring at me." And when she was triggered, when she heard her brother breathe, she felt it in her, we could see a flinch in her shoulders, and she felt it in her legs. And then Connor, this is interesting, he developed it in Afghanistan. You got on patrol, right, and you're always on alert. And they come back, and they're in really tight quarters because air-conditioned spaces at a premium, and they're eating together. And if Connor heard a crunch on his right side, he'd flinch to the right, and his right arm would clench up. And if he heard it on his left side, his head would flinch to the right, and his right arm would clench up. So it was very much a specific muscle reflex that occurred regardless of where the sound was. So we wanted to validate this. So Leighton Gramp and Dr. Michelle Lopez and I did a study where we wanted to visually see it. So the previous study that reported the shoulders and the neck and hands, that was all self-report. And self-report is inherently untrustworthy in studies. So we wanted to verify this independently. So we had 3 people. We watched them as they heard small triggers, and we could see the flinches in them. When that was very, very weak, we wouldn't see it, but then a little bit stronger, we would see it every time. And then we measured it electrically. So we had the electrodes hooked up to the muscles, and what you see here is this is an inaudible pulse, and then the trigger occurs here, which doesn't get recorded because it's a sniff, it's at higher frequency. And then here, a couple of hundred milliseconds after the trigger starts, we see this person's deltoid muscles and her calf muscles flinch. And then for auditory triggers, visual triggers, that was auditory. So here's a 3-second open mouth chewing. She could not hear this, it was visual only. And we see, oh boy, here the calf muscles are firing, and the paraspinals are firing, and the deltoids are firing. And all of those are muscle flinches that she's having while she's exposed to this trigger. So we verified this physical flinch independently in 3 people. So kind of a little bit of the stimulus response theory for misophonia is that the stimulus that's going to become a trigger occurs, and then there is a physical response, and the physical response is generally part of something that's an emotion. So if I'm angry, I might clench my fists. If I'm having anxiety, I might flinch my shoulders. If I have a concern or I'm shocked, I might hold my breath. And I mentioned the one about some of these others already, so I'm going to move on. But essentially, what's happening here is that the brain is perceiving a stimulus, which 99% of the time, the first trigger is an auditory stimulus. There's some emotion, and then there's a physical flinch. So it may be crunch, ooh, and a little flinch, crunch, ooh, crunch more, and it goes from just the sound with the flinch, and the brain integrates this together, and then it kind of goes, sound, ooh, I can do that flinch for you, and then it's annoying. I can keep doing it, so I'm like tasering you, and the emotions build up, and it becomes trigger, flinch, rage, and it just occurs so much together that it seems, for most people with misophonia, that it's simply trigger, rage, or disgust. This physical flinch is a key part of misophonia. And these flinches occur in other people, in other situations. Dr. Eugene Lipov remembered as a trauma center surgeon, his pager would go off and he'd kind of go, oh man, what am I going to have to deal with now? And after a few months of having the pager, every time his pager went off, his shoulders went up. And I did a survey with doctors that said, did you develop a unique physical response to your pager? And 6 said yes, and 4 said no. So it's a small sample, but hey, this is kind of a common thing. And I've had other professionals report this. People who get stressful phone calls may have a clinch somewhere. Had a friend who had an assignment overseas where he had to deal with stressful phone calls. He talked about his shoulders going up. He said, but I don't think that was a reflex. I said, okay. When you got home, you no longer had this assignment, and your phone went off. Did you experience anything? He said, yeah, my shoulders went up. He said, and I changed my ringtone. So, and then I had a friend with chemotherapy who had a spasm in her back muscles every time she had the sound and the sensation of her chemotherapy pump. So this is very common. And the emotions in emotional studies, they did this study with these very docile rats, and they had them in a cage where they could shock them. And when they shocked, they would stand up and hit each other for just a little bit and go back down. Stand up, hit each other for a little bit and go back down. So the rat hadn't done anything to each other, but humans, mammals, when we are assaulted, it generates an anger response. And so the emotions are very natural as you start to be assaulted. And often they're tied to the person who started this, and so that it's an extra boost right there. So how does misophonia strengthen and expand? And this is important to know to manage your misophonia so that you don't let it develop any more than you have to, or than it does, and you know how to bring it down. So misophonia gets worse when you're triggered repeatedly. So real life experience with misophonia triggers where you're having this, what I call meso distress, tends to strengthen the physical reflexes and the emotional reflexes, so that in the future you have stronger physical reflexes and stronger emotional responses. And if you're tense when there are triggers, then that also causes you to have a stronger response and can escalate in the future. And you can get new triggers by having a stimulus that's paired with an existing trigger. For example, the crinkle of a package will often trigger people. And if I have my bag of chips, it's crinkle, crunch, crinkle, crunch. And that crinkle in the brain, it happens together, it's integrated. Crinkle becomes an independent trigger. So you pick up triggers while you're being exposed to other triggers. And you don't want to really get tough. I've talked with a number of people, many people who've decided, I can do this, I'm just going to be tougher than misophonia. But if you get tough with misophonia and you face it head on, then what happens is you experience this misophonia distress, and misophonia usually wins and gets worse. So I mentioned the fact that if you have a stimulus paired with the trigger, that it can cause a trigger. You also can have situations where a person is a little bit tense and they have a similar sound or from another person, and they go, oh, that's that one, and they flinch to it and develop that as a trigger, so it expands to different people and slightly different sounds, and that just keeps spreading. But the other thing I found from that study we did where we tested people for their reflex, that 40% of the people had different reflexes for different triggers. So for a sniff, I may clench my fist, and for a crunch, a mouth trigger, my toes may curl. And that means that they develop misophonia independently twice to get that different physical reflex. Remember, neurons that fire together wire together. So experience with these stimuli become integrated with the physical emotional responses. And essentially, this is brain plasticity at its worst. Now, how can we get misophonia to decline? Well, one of the things we can do is we can break this meso strengthening cycle. And we'll talk about ways to do that. One way is effective treatment. And we'll talk about some effective treatments that are being brought out, some that have been here for a while and getting better. And we find also that if you can relax when you're entering a trigger situation, that instead of getting a response to here, you get a response to there, and you can have it work down. That if you're relaxed, you get a weaker physical and emotional reflex, and that produces in the future weaker physical and emotional responses. If you improve your health and wellness, that also helps to bring down the physical and emotional reflexes, which can in turn reduce the future responses. And if you can relax your initial physical reflex muscle before a trigger, that can also reduce the future response. And I'll talk about that more during when we're talking about muscle training, muscle relaxation training. So again, neurons that fire together wire together. And so if you're having these reduced experiences with the triggers, then your misophonia can decline. And that's brain plasticity at its best. It's typically, a person takes a lot of work at that to make that happen. So in summary, misophonia is a multisensory disorder. It's typically auditory and visual, but it can be any sense. Misophonia is an acquired initial physical reflex disorder. That's this box right here. But the most powerful, noticeable feature are the emotions. And so both the physical and the emotional responses are strengthened through typical exposure. And so I like to refer to misophonia as a conditioned aversive reflex disorder. So now about management and treatment. I think we're right on schedule. So we find that there's an inverse, an opposite relationship between health and well-being and the severity of misophonia. So if my misophonia is high and my general health and well-being is low, and I'm doing things to improve my health and well-being, then the misophonia comes down. I didn't say it goes away. I just said it comes down. So, we have scattered reports from various health treatments. There was a woman who eliminated her misophonia by taking magnesium. Everybody in the misophonia treatment and management group wanted to know what were the amounts and what were the brands, and let me try this. Well, didn't work hardly. I didn't see any other people who it worked for. But when I talked to this woman, she had a leg injury, she had chronic leg pain, and when she took the magnesium supplements, her leg pain went way down. So her health and well-being went way up, and her misophonia virtually went away. So you can also see it from dietary changes. If you had food sensitivities, don't eat the things you're sensitive to, because anything that disrupts your body is going to make your misophonia worse. So there are some people who do dietary changes, and their misophonia improves, particular diets, and their misophonia improves. But again, that's very much personalized to what improves the health and well-being of an individual person. It does not mean that misophonia is caused by diet. That's not the case. It's just an irritant to the body, which makes a person more susceptible to misophonia. Now, there's some evidence and reports that medication for anxiety and depression can help, but there's many cases where people take the anxiety or depression medicines, and their anxiety and depression goes down, but their misophonia doesn't. So it's not, again, if it helps you feel better, it'll probably improve your ability to handle the misophonia triggers, and therefore reduce the severity. It may not reduce the impact of individual triggers. Another thing is improved sleep, exercise. Both of those things can improve your health and well-being, reduce your misophonia severity. You can reduce your stress, and so if you can improve cooperation of the child with you, if you have the misophonia, or cooperation of the child with the parents if the child has misophonia. Sometimes as adults, we need to reduce the demands we have on our life. Our life is too full and too pressure packed that we should reduce some of those demands. And then sometimes, there's just environmental conflicts with family, criticism, coercion, negative events, yelling. Those things, again, increase the stress and make the misophonia worse. So one of the things that you can do with a child, either a child that has misophonia, siblings of a child with misophonia, or children of a parent with misophonia, is to improve the children's cooperation in the family. And behavioral parent coaching is very effective at this. My primary career focus is parenting dynamics and smoothing out families, making everyone in the family more cooperative and pleasant. I'm getting a note that I may be experiencing some connection difficulties. I hope everyone is getting this okay. Okay, so the way that works, the parent coaching works, is that I have a weekly session with the parents, not the kids. We talk about specific scientifically sound behavioral plans to address the behavior concerns. So if it's non-compliance, we want to increase cooperation and compliance. If there's physical conflict, it's keeping hands and feet to themselves. If it's non-misophonia emotional outbursts, that's staying calm and in control. And maybe for misophonia, it's following the family plan, which I mentioned down a little bit later. And then the next week, we review how it went. We make plans for the following week. We implement those plans. And usually this is about a 10-week process to address virtually all of the compliance and conflict situations in the home. And it generally eliminates all repeating problems, conflicts, and it really elevates the mood in the home. Everyone is happier. Okay. Okay, so with misophonia management, some of the things we can do. So we know that the misophonia the strength of the physical and emotional responses are strengthened with real life experience. So you really want to avoid this getting tough and facing down the trigger situations. Avoid misophonia distress. Now, how do we do that? Well, one thing we can do is we can add a lot of noise. And noise is a component. This is what Marcia Johnson initially introduced as the misophonia management plan. You know, the effect of noise is kind of threefold. One is that when it's very quiet, your ears turn up the sensitivity, and therefore sounds seem louder, they're more noticeable, and the fidelity, the clarity is much better. And so if you will just add background noise, then it reduces the mesophonic response. And in some cases, this is extremely positive. I worked with a young woman. She was, I think, college age, still living at home. We had the first session. We talked about using noise, using her earbuds at times. When we talked about having a second session, she said, no, everything's fine now. It was enough of a difference. It just made her life much better. You can add noise in a number of ways. Box fans are cheap and very noisy. They're like $16.88 at Walmart, and you can set it against a wall and it just roars and doesn't blow wind, and you can let it blow in the summertime. Sound machines using a kitchen exhaust fan. These open ear headphones, these little guys like this are terrific, and it just kind of hangs on your ears, doesn't block your ears. The normal iPhone earbuds are just fine, and you can use an audiologist provided sound generator. And the noise, having that noise there, the sound generators are also called a masking device, or you can use an audiologist provided hearing aid device like this one. Okay, I'll hold this up here, and play noise through your iPhone or Android phone. And TV and music are less effective than noise because TV and music have silent spots and loud and soft, and with the noise you can match the kind of noise that does the best reduction in the trigger. Noise canceling headphones, the Bose ones are great. I do not know about all the other headphones. Some of the older headphones like the Bose QC15 blocks the background noise, lets the triggers through. That's not what you want. The QC30s are great because they're a little collar and the earbuds, and if you have long hair, you can wear these. One woman wears a scarf and has her hair down, and no one ever knows that she has these on. And the QC30 and 35 have the ability to adjust the amount of noise cancellation that you have and adjust the volume. It's great. You can get noise isolating headphones. I don't like this particular ear tip here. I like the one that's more like a foam ear tip, like an earplug. They're comfortable. They block more noise than the Bose, but you can't adjust the amount of sound that's coming in, which is really good to be able to adjust it to a level that you can interact with the world around you and reduce the triggers. And then there's, for children, there's things like these Hamilton Burr Schoolmate, which are just they're earmuffs with a cheap little headphone inside. Selective avoidance is good because you want to avoid physiological distress. So do not stay in a horrible situation where you're getting pelted by the triggers and you're experiencing this distress, because if you do, you're increasing the level of the misophonia severity, and you're making you miserable at the same time. So you can use headphones and noise. You can reduce the number of triggers you're exposed to by having a good plan with the family as to where people are going to eat. I cover questions at the end, okay, Laura? Actually, let me see if I can open that up. Now I can't see how to get to it. I'll cover that question at the end. So you may need to eat separately. You may need to have preferred seating for different individuals where they're not looking right at their brother if that's the trigger. In school, they can have a hearing assisted device, which is like headphones, where the teacher has a micro lapel mic, and you want to be able to escape the triggers in the classroom. Leave the classroom, go to a trigger-free area, calm down, and then come back. We do not want total avoidance of misophonic triggers, because if you structure your life around trying to avoid triggers, you will make your situation worse. You will limit your life. You'll increase your worry and awareness of triggers. So that does not work well. Okay, so you can misophonia qualifies for accommodations under the Americans with Disabilities Act. I'm not sure what we have in Canada or the UK or Australia, but in the US, you may often need a diagnosis from a licensed professional. You may get that from your physician by bringing them information about misophonia. That you may be able to find a misophonia treatment provider who can work with you. Most audiologists who know about misophonia that are listed, there are more audiologists listed on as treatment providers on the misophoniatreatment.com website than any other profession. There's no specific disorder or condition required for ADA accommodations. In the ADA document, it says that a disability is a condition that substantially limits one or more major life activity. And it lists examples of learning, speaking, listening, reading, writing, concentrating, caring for oneself. Well, misophonia definitely impacts the ability for one to listen. It impacts your concentration extremely, and the level of distress that it causes means that there are many basic things that you cannot do while you're exposed to the triggers. So for students, accommodations, are needed to so that can perform as adequately as a non-disabled student. This is defined in Section 504 of the Americans with Disability Act, and so you're looking for these from the staff. And I want to say that if you can get your teachers to cooperate, that's much better than trying to force it. And if a child needs to wear headphones in class, you want to make sure you tell the teachers that the noise improves the child's ability to hear and listen to the teacher. So it's a positive thing, not a way of avoiding the class and avoiding hearing the teacher. Okay, accommodations for students may be things like no eating or drinking or gum chewing in the classroom, and that's getting to be much more of a problem because people believe that it's good for kids to chew gum in the classroom, helps them concentrate. Child be allowed to leave the classroom without permission, without penalty, to be able to use headphones and a noise generator app in class, and also during tests, have a trigger-free location for testing if needed, preferred seating to reduce exposure to triggers, and maybe having that hearing impaired transmitter receiver so that the child can listen on headphones. College students can have the above, plus get a private dorm room at no additional cost, no penalty for missing class, and maybe have access to notes from the class. So before I go into this next part, I'm going to mention earplugs. So earplugs can be very, very beneficial for sleeping, for taking tests, for limited areas of time, where they're not encouraged for long-term use. And to put an earplug in like this, anything that's not in the ear is of no benefit. So this is a 3M earplug, E period, A period, R period. I don't know what it stands for, but these are the standard commercial earplugs. You can get them on Amazon, box of 200 for $25 or so. And you can roll these things down, and I like these because they will hold their little toothpick shape, and you can run these things down and then just put them up to your ear and wiggle them and just put them all the way in almost. And obviously you don't want it to have it be uncomfortable, but when they're way in there, all of the material is in the ear canal, and they're extremely, extremely beneficial. And then I just use my fingernails to reach up and pick at it a couple times. But I do have to pick at it a couple times, and then I can get it out. So just want to make that comment about the use of earplugs. Okay, let's move on. See what? So here's a management trick for you. This management trick I call no threat, but thank you. And what I want you to try right now, your microphones are muted. So at least I think everyone's is muted. And so in fact, I'm just gonna check that too. Attendees, make sure everyone is everyone's microphone? Yep, everyone's muted. Okay. So what I want you to do, since you're muted, is I want you to say a nice strong thank you and smile, and see if you get a warm fuzzy. Now, if you can get a warm fuzzy, it can wipe over the miso yucky. And so the horrible, ugly, whole body trigger that I hear you get, I don't get it. But when you're triggered, or that kind of response can be washed away by this, what I call a gratitude reflex. If you get that warm fuzzy, so the trick here is to talk to your lizard brain. Your lizard brain is your autonomic nervous system. It's your best friend, but it's confused when it comes to misophonia. So you say, hey, lizard brain, what you heard, that sniffing or that chewing or whatever, is not a threat on my life. But thank you. Thank you very much for trying to protect me. Now, the short version goes like this. No threat, but thank you. Smile. Or thank you, but no threat. And if you can say that thank you strong enough to trigger that positive reflex, because thank you has been paired a million times with feeling good, then it can help. So one sufferer made this comment. Says, I was stuck in the car next to my husband on the way to the coast, facing 3 long hours of sniffing and crunching potato chips. Much to my surprise, I didn't feel like jumping from the car onto the freeway when she used this trick. She went on to say that she'd used it for snoring of her husband on this trip. And then she concluded with this. She says, it won't take the problem away. But then again, you probably won't be featured on America's Most Wanted. So give it a try if you wish, and see if it works for you. Okay. Do I have to click there? Okay. Another thing you can do is positive self-talk. When you are triggered, you have extreme negative thoughts. I get this in a list of emotions and things that people feel, and you want to just like, in your brain, you're talking about how horrible it is and how ugly it is and how gross it is and how disrespectful and impolite and how they just be, well, I won't say what you think in extreme cases, but resist the temptation to think and verbalize what you feel. Decide to say something else, okay, and then do it. So you may think it's just a sound, or oh, that person is sick, or they can't help it, or I'm glad one person found that when they were at a dinner, they were at a Mexican restaurant. Of all the places to go with misophonia, they went to a Mexican restaurant, and there was a family at the next table eating all the chips and salsa that come at the start of the meal. And she says, well, I'm glad that family can enjoy eating together. And she smiled. And she said for the rest of that dinner, she never noticed the family. Now, these are not things that are going to work for everyone every time. You know, like, I know my friend loves me. But you have to think something positive and do it, because what you're trying to break here is that automatic negative complaining talk, which then every time you say it again, you're very likely to trigger yourself again. And so it just makes it worse. So you don't want to do that. Okay, treatments for misophonia. Dr. Marcia Johnson recommended that these be considered management techniques for misophonia. So whether you call it treatment or management may depend upon who you're listening to. So the misophonia management protocol was developed by Marcia Johnson early on, and then the Jastreboffs used this tinnitus or tinnitus retraining therapy, and they just kind of did a modified version of that for misophonia. So in both cases, you use a sound generator to reduce the response. For the misophonia management protocol, Dr. Johnson recommends, this protocol says, have counseling, some form of therapy, and just try to calmly get on with your life and deal with misophonia as a kind of a chronic, irritating, but livable condition. With the tinnitus retraining therapy, that program gradually increases all sound and then increasing the triggers. And again, it uses the sound generators. I'm not sure how well that works. Let's look at the outcomes here. Marcia Johnson presented, I don't know if she pulled 100 cases out of her like thousands that she has, but she pulled at least a good number of cases, and she classified the people to start with as either mild, moderate, or severe. And then she looked at their follow-on rating of their misophonia assessment questionnaire as mild, moderate, severe. And essentially, on average, what she saw, that it reduced the misophonia severity from one level. So it reduced it from severe to moderate, or moderate to mild, or maybe mild to virtually gone. So that was her pulling of the data. Now, that wasn't real scientific, because we don't know how many fell out, didn't report. But again, that's a positive indicator of the use of the sound generators. And I think something like 60 to 70% of the people who go in to see Dr. Johnson end up choosing to get a sound generator, because some people just want a letter of accommodation and appreciate it and like it. With a tinnitus retraining therapy, the Jastreboffs published an article that said that 83% of their patients, of the 182 patients that they had with misophonia, had a significant improvement. Now, they define significant improvement as a reduction of 2 points on their rating scale. And the rating scale was done as a verbal report face-to-face with the audiologist. So for one thing, if I go from a 9 to a 7, I still have pretty significant misophonia. And if there's a tendency to give an answer that the therapist wants. So it's hard to say how beneficial this really was. And there was no data provided in terms of a mean, standard deviation, or in like buckets of different levels. So again, we get a lot of reports of people appreciating this, working with an audiologist, and audiologists now, a number of them have people who are therapists that they kind of coordinate with, that they've identified, who know about misophonia, that can help you that way. So this is a very reasonable approach to address misophonia and make it a livable condition. So there was one CBT study published by, I think it's the University of Amsterdam, and the people there, the Aaron Schroeder and company. They had 90 participants. They set a criteria that they had to have a 30% reduction in the AMISO-S score, and very much or much improved on a general severity effective treatment rating, basically. And in the treatment group, had education about misophonia. They talked about moral values related to triggers. They worked on task concentration to try to focus on mindfulness. What am I doing at this time right now? And not worrying about things I shouldn't be worried about. They did relaxation exercises. They did took recordings of their triggers and changed the frequency and the voice, and things. They also did some counterconditioning work, trying to have positive stimuli accompanying the triggers, and they worked on some management techniques of using noise and earplugs, et cetera. And they found that they had about 50% what they considered a positive response to the treatment, 50% of the people. Now, I do want to say that if you're going in, if you're looking at doing cognitive behavioral therapy, beware of very, very powerful rewards. So I'm talking something like a trip to Disneyland, right? That says that you identify the inappropriate behavior, you identify what the appropriate behavior is, staying calm, eating dinner with the family, being polite, and then the child, especially if it's a child, tries to stay there and learn to stay calm enough to not scream and yell. And you can eliminate this inappropriate behavior, the yelling out. There's cases of doing this. And then they get the final reward. They worked at this for 2 months, and now they're not yelling anymore. They get the trip to Disneyland. Now, one of the problems is that if they're still kind of enduring the discomfort of misophonia, then they haven't really affected the initial physical response. They may be able to stay calm and not have the distress, but you run the risk that with time, because it's continuing to happen and they're kind of stuffing it, they're getting tough with it and enduring it, that the response can strengthen and that it can return with greater severity and more triggers. So this is a risk that's run here with very powerful rewards. With smaller rewards, little things that make the kids happy, if they can do it and they're happy, then the happiness can kind of help overcome the emotions and the physical response, and you'll see that would kind of be similar to what I call counter-conditioning or the trigger games. So there's a great study. This is a brand new study. They've just about finished up. I believe they finished the treatment of the participants in this study, and they're trying to write it up in the spring and get it published. Dean McKay and his group at Fordham University, Dean made this presentation for the Misophonia Research Symposium last August, and it used exposure and stress management. Now, we've heard a lot of bad press and a lot of bad comments about exposure therapy. Avoid exposure therapy. Don't do exposure. And when we get these stories, it's from therapists who had no idea what misophonia was, no idea about how it got worse. And they'd tell an 8 or a 10-year-old, hey, sit there in front of me while I eat this bag of Fritos and it'll all be better. And the answer was it didn't all get better. It got worse. So there's multiple reports of even in the Amsterdam study, when their initial pilot work, they had reports that regular exposure makes misophonia worse. Now, there's a theory of, first off, that's bad exposure, right? That is not appropriate use of exposure techniques is what the research shows. But there's something called habituation. And habituation is where you're having a stimulus and a response, and the stimulus basically dies out effectively, or the response dies out. So why do people live on a pig farm and not complain about the odor? Well, the answer is because their noses, their olfactory senses habituate. They actually stop responding, so they don't smell the pig stench. Now, for a more therapeutic situation like a spider phobia, a person may sit down in a room, and at a distance you show them a picture of the spider, and they start to have a little bit of fear and that kind of anxiety and the physical response. And then with a while, it just declines, and they habituate, and it goes down. And then you can use the spider a little bit closer. So that's habituation of a response. But misophonia, habituation for misophonia typically doesn't work. For one reason, when you're listening to a trigger like chewing, that it's crunch, boom, crunch, boom, crunch, boom. And so you keep getting hit by it. And then the second thing is because you're getting hit by it, you may want it to decline, but it usually doesn't decline. And so Dr. McKay used the inhibitory learning approach, which uses multiple varied presentations, and it also uses extinction during what's called the memory reconsolidation window, and I've expressed my full understanding, 100% of my current understanding about what they were doing, so I can't go into it anymore. But let's look at their results. So if we look at this, this was the Misophonia emotion and behavior scale of the questionnaire that they used. And it started up here, I believe this is about 30, and it dropped. So the red line uses stress management and then exposure. The blue line is exposure first and then stress management. And so it came down better to, looks like about 9 for the exposure and then stress management. And then looking at the symptoms, this is 5, 10, 15, 20. We're at 19, 18 to 20 here, and it drops down to 6. So this is average of the people who completed the program. This is what was presented by Dr. McKay at the research symposium. And I think this is very, very encouraging for their first attempt at this. Now, dialectical behavior therapy is practiced by Jalene Jaffe. Dr. Jaffe has been working on misophonia at least 6 years because she talked about it at the first Misophonia research symposium. I believe at the first one, maybe not, but she was definitely at the first Misophonia Association, and I think she was at the first one that was by the tinnitus group, and that I was at also. Anyway, the dialectical is talking, so it's how we talk about our situations to trigger, how we think about those, and it has much more to do, a lot more similarities with like acceptance and commitment therapy that I'll mention, rather than trying to say, oh, don't think about that trigger over there, because that trigger, if you think about that trigger, it's going to, well, that doesn't work, you know, because you try to not think about it, you think about it. And so you focus attention away from the triggers, you work on being calm and accepting this. I love this one thing that Dr. Jaffe says. So a person says, well, why me? And the response, and she says where she got this, but she says, well, why not me? Right? I mean, it's going to happen to somebody. Why not you? And so she also works with people giving up being an etiquette police. She probably works with them about the things that they say in their mind when they're around triggers. But basically, this calming down, and people learn that they can go back into school. They can live with their triggers. Not saying it's all gone, but she reports many positive cases, but we have no hard data. Jalene, we want to see your data, okay? Because we know you're doing good work. And Jalene works by video chat also. Okay, Sequent Repatterning hypnotherapy. This is great. I went out on a cruise when I was first learning about misophonia, and there was an entertainment hypnotist, and I came back looking for someone because they had reported that traditional hypnotherapy didn't work at the Misophonia Association convention in 2013, I think it was. And so I was looking for someone, couldn't find anybody locally, went on YouTube, and there pops up Chris Pearson, and he's talking about a treatment for misophonia using hypnotherapy. And so this is a specific program for misophonia it's underpinned with proven neuroscience techniques. It brings together the different therapeutic approaches that have been used for a number of different situations with misophonia. It consists of typically 8 consecutive weeks. Sometimes it can be a little longer. For a child with short attention span, it could be 16 half lessons, but it needs to be a consecutive, it's a sequential process. And it can be delivered by video chat. There are 3 practitioners who work by video chat and a total of 5 trained hypnotherapists, all in Europe. We're trying to get more trained. Any hypnotherapists out there, we would like you to be trained in this. because there's people who need your help. This can be used, a child needs to be 10 years old to do this treatment. Under 10, they're not ready to do all what's necessary for this treatment. And with hypnotherapy, you have to drive the change. A hypnotherapist cannot do anything to you. What they do is help you do what you want to do. So let's see a little more about it. Okay, so I'm going to talk about the treatment as the way it was originally formulated, in fact, everyone to date. And then I'm going to show what happens when you add in memory reconsolidation. And note that Dr. McKay, one of the things with the inhibitory learning theory I used for exposure was making use of this memory reconsolidation. So what happens is you have some event that happens to you and it's stored into long-term memory, long-term storage in your brain. And then you have to think about it and bring it back into your awareness where you can talk about it, tell about it, remember it, whatever. And then it goes back over the same neuron pathways into your long-term storage. So if a person had the old fish story, I caught a fish that was this big, and then they tell the story, and well, it's about this big. They tell the story again, it wasn't, but probably is like this big. And then they're telling, yeah, you know, it's like probably this big. Well, maybe it was this big. Well, what happens is they keep remembering the bigger and bigger size so that they actually remember it as this great big fish. So that's with memory reconsolidation. Now, if you can, in fact, bring the misophonia event into memory and not have all of the horrible associated responses with it, and then store it back into long-term storage, you overwrite the neuron pathways of the original event that had all of the ugly remembrances of all of the horrible experiences. So that's what memory reconsolidation is. So let's look at these two graphs here. So this top black graph, notice how it's pretty much consistent down through the fourth session. This shows the path of all of the people who were treated to date through several hypnotherapists. And that was almost 500 patients. That's a lot of people being treated with sequent repatterning hypnotherapy. And it went from about 44 down to about 21. Not bad, right? Well, by adding in the memory reconsolidation as needed, then you find you get an improved benefit. So with the last 80 patients, the average response brought it from 44 down to 12. That's an enormous reduction in misophonia, and that's the average response. Now, at the Misophonia Association convention, Chris Pearson was asked, well, what's, you know, how many of your people respond positively? And he said, well, if you take a criteria of their severity coming down by 20% or more, about 80% of the people respond positively. So unfortunately, that says there's 20% that don't. Yet that's still pretty good odds. And I will say again that you have to be willing to work and change. You have to be willing to choose the path to do something different, and then let the hypnotherapist help you do it. And you have to be cooperative with the techniques that the hypnotherapist asks you to do. So if they ask you to do some little exercise that takes 5 minutes a day, do it, right? And if you don't, you say, oh, I didn't have time for that. Well, you know, you're basically saying you're not willing to put in the work. You don't maybe really wanted to change that much. And so some people do not respond to this. Okay, acceptance and commitment therapy, or ACT. It was developed from behavior science, something called relational frame theory, which is really a scientific analysis of how our minds work, the way we use language. And the acceptance part is really acknowledging that, you know what? Life is going to have unpleasant experiences. Life's going to have some worry, some stress. some anxiety. That's just the way life is. And what it shows is that when you try to avoid excessively rather than accepting and experiencing, that it makes it worse. It ramps it up worse and worse. Where if you can just accept it and let it be, then the stress and the problems come down. So this is avoiding avoidance, accepting, recognizing that thoughts are not facts. Just because we think something doesn't make it so. Just because we say we're stupid doesn't mean we are. Deciding what values we have that we really are important to us, being in the present moment, not living in the past or the future, and then being committed to doing what's important to you. And that's basics of acceptance and commitment therapy. There was one case reported that was very successful with this, but in the report, by the way, if you have anxiety and stress, this is a really good non-misophonia treatment. This is really what's called the third wave of therapy. And that the person who did so well with this in a case study really liked the concept of accepting and relaxing into the situations where there were going to be triggers. And that may have fact been one of the major factors of them responding well. So we don't have a lot of data on this, but make you aware of it. Now, there's something that Scott Session originally called PRT. I'm not even going to write what it was there because Scott says it's not appropriate anymore with what he's learned. My daughter and granddaughter were the first to be treated by Dr. Sessions, who has a doctor of chiropractic, but he's not your normal doctor, your normal chiropractor. For example, and I wouldn't have believed it had I not experienced it, he eliminated my anaphylactic allergic response to shrimp. So I knew that Dr. Sessions had some special techniques and things that he was learning for more than just spinal manipulation. He's a friend of the family. He was coming to visit us. He's coming into Livermore, so I asked him to come over to show me what he could do. My daughter and granddaughter were here. He pushed and poked on them, did some muscle testing, some pressure points, some spinal manipulation, checked for some nutrient deficiencies and some other things. And all of a sudden, they stopped triggering. And the little girl who had the foot jerk, that was my granddaughter. And when I was getting ready to treat her with another method of treatment that I was working on, but you know, after Dr. Sessions visited, her foot's just laid there and nothing happened. They didn't move. So there is a waiting list for new patients. He only treats one patient per week, and he's working mostly on callbacks, trying to improve the treatment. Right now, with new patients, maybe 60 to 65% will leave his office without any triggers, and 8 to 15%, somewhere in there, have no effect. He doesn't. That's why he's working with these people, trying to. He wants 100%, and God bless him, but you know, what he's got here would be very good if we could have people providing this in every state of the United States and the UK. And then for maintenance, if their triggers go away, and then they may come back up, and about 50% have some regression, and about a third will come back and work with him, do some more work. Most are still improved when they're returning. For example, my daughter, who was treated by Dr. Sessions in my home, she developed a new trigger to her kids, the kids swinging their legs, and it wasn't a trigger she had before. She developed a trigger, and then she relaxed it away using muscle relaxation. But people, just because a person gets rid of their triggers, doesn't mean it's going to stay away. Doesn't mean they can't redevelop it. And if they go back into the same and stressful environment where there's a lot of angst and worry and concern, and then all of a sudden, boom, the triggers come back. So anyway, so the goal here that Dr. Session has is to establish a protocol and then to train other chiropractors. Okay, now we'll look at functional neurology. I am not an expert in functional neurology. This is a specialty for chiropractors. All the information I'm presenting here was from the presentation of the 2018 Misophonia Association Convention up in the Minneapolis area by Dr. John Hatch of Utah. And functional neurology does tests of the reflex response, primarily of the eyes and a balance and a little bit of timing. And these exercises are looking for deficiencies in the reflexes. And so then they provide exercises to overcome these reflex problems. And they say that the specific reflexes indicate specific areas of the brain which are not functioning well, and therefore the exercises are going to develop improved functioning in those areas of the brain. That's their theory. I will say that you know, if in fact a person does have a reflex response of their eyes drifting or something, then they're going to be loaded down, you know, with processing, with trying to control those reflexes. So they do a vestibular test, which is a vertical posture. Do you lean front or back or left or right? They do a standing stability test on a stable surface and unstable surface. And they do these tests with your eyes open and closed, with your head up, your head down to the left and to the right. And then they also, and so those tests then give an indication of what exercises are to be done. They do a metronome test where you're trying to match a visual to a hand movement and match the rate at different locations. And they do eye fixation and tracking, so that when you fix on an image, your eye should be stable. You shouldn't have one eye drifting off and back. And when you track on something, your eyes should follow uniformly. So they provide these physical brain exercises that are assigned. They're supposed to be done like 3 times a day. And even in the first week, you see changes in the tests, the measurements here. And then the person needs to do these tests for 3 to 4 months. Dr. Hatch says that it takes 3 to 4 months of doing these exercises to create plasticity, meaning to create change that sticks, that lasts. So he presented some data from a survey. He sent out the data to 100 patients. He got 30 responses. One question was, how would you describe your ability to better manage your triggers following your treatment? A great deal, 7%, a lot, 20%, a moderate amount, 23%, a little, 35%, and none, 15%. Then there was a question after treatment, do you feel you have fewer triggers? A third said yes. Same number of triggers, 64% said that, and more triggers was 1 person out of 30. Following treatment, how would you rate the severity of your triggers? 12% said much better, 43% said better, 39% said about the same, 6% was worse. And how much has your quality of life improved since you visited the brain rehab clinic? A great deal, 7%, a lot, 20%, a moderate amount, 18%, a little, 40%, and none at all, 15%. So at the symposium, there has been a lot of talk on the internet groups about neurofunctional neurology curing misophonia. This is what Dr. Hatch said at the Misophonia Association. He said 85% responded a little or more. And again, do I give them the ability to better manage it? No. What Dr. Marcia was up here talking about, what Tom is talking about, you have to apply all of these. You don't just apply functional neurology and stop. I believe that every little piece of the puzzle is used in rehabbing the brain. I'm not going to give you one way to cope with this mechanism. All I'm going to do is rehab your brain and hope, I may have that wrong, that your brain rewires in a way that is supposed to, so you don't feel the same. Maybe it is. It helps to rewire your brain in ways that you don't feel the same. The techniques that these other practitioners have shared will boost it and take it to the next level. For me, in my world, a lot of times, if you fix the brain, then you can go to your therapist and use EMDR or hypnotherapy or whatever, or any psychology buzzword, and it will work because now your brain has less fight or flight response. So that's functional neurology. So a little bit about progressive muscle relaxation. PMR, I really think it should be called maybe muscle relaxation training. It was developed in the 1920s to deal with high blood pressure and anxiety. When you tense and then relax while concentrating on the muscles, what you find is you develop the ability to relax that muscle on demand. You want to follow a guided audio. I ask people to do it 3 times a day if they really want to address their misophonia, because I've had people who say, well, you know, I've done PMR. I've used PMR. I did it, you know, like 5 or 10 times, and I know how to do it, but I didn't really see a big difference. Well, the answer is you have to do it a bunch because it's skill training. It'd be like saying, yeah, I played the violin for, you know, 5 or 6 days, but nah, you know what? It doesn't really work for me. Well, it takes practice. So this is muscle relaxation practice, practice, practice. So after you've done maybe 10 to 14 times, 10 to 15 times, then you can do sequential relaxation, which is think of your jaw, relax. Think of your fist, relax. Think of your arms, relax. Think of your, you know, torso, relax. And you just relax, 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 relax. It takes about a minute, 1 to 2 minutes. Just step through all of the muscle groups. And then you want to do a total instant relaxation where you just go, relax. Okay, wake up. And that's the application for misophonia, is to relax on demand. Relax when you're going into a situation where there's going to be triggers. You know, you're student going into a classroom, relax. This is really hard for kids. This is really much more of an adult thing. Relax before you go into your office. Relax before you go into a meeting. Relax before you go into your home. Relax immediately after a trigger can shorten your anger and distress response. But if you relax before the trigger, and especially if this is your, let's say, your reflex, if you relax, then if it's crunch, oh, relax, crunch, oh, relax, then what the brain is seeing is, I heard the crunch, I flinched this muscle, it's relaxing. So I'm seeing crunch, relaxing muscle, maybe I'm doing the wrong thing. So it actually changes the future occurrence when you can relax in advance of the trigger, be triggered, and then go right back into that relaxation, especially if you have a distinct muscle response. So again, this is for adults with a strong, distinct initial physical response. It's a powerful treatment for misophonia. It can also help improve your overall health and well-being. And it can actually be an inoculation against new triggers. You're becoming irritated, relax. Oh, okay. So the skill, the ability to relax on demand is powerful to reduce anxiety and stress, and to calm you down, to prevent. So I really think that learning to relax whenever there's you're irritated, can be an inoculation against new triggers. Now, some specific examples. So Scott was the first person who told me about this. And he stood up in the Misophonia Association conference convention in 2015 and said, I virtually eliminated my misophonia. What he found is that he could just relax around his mom and let his muscles relax while she was talking. And he could experience triggers, and if he needed to, he could go away. He just practiced with that, and he got a little bit better and better and better until he found that pretty much in any situation he could just relax his muscles, and the agony of the misophonia would go away. So he's virtually eliminated his misophonia. My daughter Melissa developed a trigger to kids swinging their legs like this, and she saw these kids swinging their legs in her where she taught at church, and she's getting all upset. You go, wait a minute. They're not doing anything wrong. Their feet don't touch the ground. And she paid attention. And she noticed that her trapezius muscles right here were clenching up on her. And as she watched them longer, the clench got bigger and bigger and bigger. You know, she's a trained dancer. So she just said, Dad, I just relaxed my trapezius muscles. And it went away. Now, my other daughter, Amy, does not have misophonia, did not have misophonia, but started getting angry with her husband at night after the boys had gone to bed and he's eating cookies and chips. And she's getting so angry with him. What's that sound like? It sounds like misophonia developing, right? So I said, Amy, you know, what's happening here, I bet, is you're tensing up I said, now I don't know where it is, but pay attention to your body and see if you can find out where it is and relax it. And if you can't figure out the muscle, just relax anyway. So we go visit them every 2 months because boys are little. We don't want to stay connected as grandparents. And so next time I went there, she said, oh, Dad, it was my shoulders and it's gone. And I checked with her a year later and she said, you know, if I'm really tired and upset and irritated and stressed, she said, I might notice his chewing and then I just relax and it's gone. It's okay. So really, she doesn't suffer from misophonia at all. And Joe had misophonia for 20 years or more, developed it as a teenager. He's a 40-year-old burly guy. And he says, oh yeah, my kids chew around me, drives me nuts, and they do it on purpose. And so he wasn't extreme because he didn't run out of the room. We talked about this physical response. We thought it probably was in his jaw. And I said, so Joe said, when you're eating with when your family's eating, just be there, but just relax that jaw completely. And so when we're doing parent coaching with Joe and his wife. The next session was 4 weeks later. We're at the end of the program. Came back. Oh, the kid was doing great. And asked about the misophonia. He said, oh, it's gone. I said, wow, that's wonderful. How long did it take? I'm thinking a week, 10 days, 2 weeks. You know, he said, well, at first, 30 minutes. So what do you mean 30 minutes? He says, well, you know, I could feel my jaw flinching and I just kept it relaxed. And after 30 minutes, it just stopped flinching. And then the next time it'd be shorter and shorter and shorter. So again, this is powerful. These are not the only people. I've got this later, talk about a little bit about this. Now you can also block certain physical reflexes. A very small number of people feel like they're being choked when they're triggered. And so that's an esophagus constriction. Now, when you swallow, it ripples or tight, relax, tight, relax, tight, relax. It ripples down the esophagus, leaving the esophagus relaxed. And so if a person has an esophageal constriction, if they will swallow immediately after the trigger, then what the brain sees is, oh, heard that crunch, flinched those muscles, but now they're relaxed. Maybe next time I should relax. And it can just wipe out misophonia if you only have that. Now, I had another client who had that restriction, that response, but it was only for some of her triggers. Some of her triggers were other muscles. And so just trying to do that after every trigger wasn't effective. She had to really get working on individual ones. And I think she did sequent repatterning hypnotherapy after playing with that for a while. I find that a good number of people have breath-related triggers where they either gasp or they lock down and hold their breath. One lady had a fear response, but what happened, she was really skittish. So she would hear a crunch, she'd go, ah! But she wouldn't choose to, so it was just her chest jumping, and that would scare her. She'd go, ah! And so for her, scuba breathing, just breathing slowly in, slowly out. And since she was breathing, in scuba, the rule is always breathe, never hold your breath. And so she's constantly breathing. Then she's, when she's bumped with her breath, it just goes right back, and it's not felt nearly as strongly. And that can be a big help for some people to change that reflex and change the misophonia. And then paced breathing is good. Paced breathing is where you breathe in, typically breathe in on a 4 count, out on a 6, or in on a 3, out on a 5. Basically, longer breathing out than breathing in, and that triggers your rest and digest action of your autonomic nervous system. And so that's good to go along with that. Okay, how do you find your initial physical reflex? Well, if you get like if I'm working with a person over the internet, I may take a piece of celery and go, I don't know if you heard that. Just that real little bitty bit. Did that trigger you? No. Okay, let's go a bit more. Let's go a little bit more. And then we bring it up to where they just start to experience it. That's what we did in that research study, Kate Morrison and I. And then people can generally tell you, oh, I felt that in my shoulders, or I felt that down in my belly. And I go, oh, is it inside in your stomach, or was it your abdomen? It's my abdomen. or it was maybe my diaphragm. And you can also use the Trigger Tamer app, which is a free app that allows you to take a recording of a trigger, edit it, and then play it back where it's barely audible and keep it short, and you can work your way up. If you're doing some environmental intervention like noise, you don't need to know where your muscle is. But if you're doing muscle relaxation, or if you're doing maybe counterconditioning or something, then it can help knowing where your physical reflex is. Okay. Trigger games for children. This is another treatment. It's good for young children. It can be done with children with autism. It's completely experiential. It's an experiential activity where you control the trigger, you limit it, and you have an incompatible activity going on. So recorded triggers are great because you can adjust them. You can use the Trigger Tamer app for that. And then you want to have a fun event, and you can either have a fun event that's happening all the time, or more often you'd use the trigger as a key to do a fun event. So the trigger starts to play, and dad starts tickling or wrestling or pillow fighting or having a Nerf war. And the parents face off, and then the parent needs to attack in the first half second. It's got to go right away because we have only a 2 to 3 second training window. And again, you need a response that the child is going to be going, ah, instead of going, ah. That's great. Got to be fun for the child. The Trigger Tamer app saves the session data, so you can actually look at your progress with different triggers. You can send it to your therapist or to your clinician, and it gives you repeated measures of the strength of the stimulus that you're using. So an example might be crunch, tickle, crunch, pillow fight, a child dancing and tumbling around the room. Found that a hand grasp isn't exactly the right thing you want for a pillow fight, because if it's crunch, you're going to swing a pillow, you're clenching down and you're holding that. So that's the muscle you want to change. So knowing that reflex could be important there. And you have to treat each trigger individually. And we have several case examples. One little boy, when they did it with the dad, they were wrestling, they called it a cage match. And when it was just the boy and the mom, they did pillow fights. And the responses just came down. So this is something that if you do it and it doesn't work, something's not right. Don't keep doing it. You should see some results fairly quickly. Okay, another treatment. This is one that I developed. I call it the neural repatterning technique, which is a counter-conditioning treatment. And with it, it uses a recorded trigger that you can change the length of the trigger and the volume of the trigger. So you can bring it down to that level where it's just barely starting to trigger you. You want to have a positive or a relaxing playlist, and the app intersperses the triggers in very small spots under your control. You want to keep it happy, positive, and then when the situation is right, the reflex can decay. Now, each trigger has to be treated individually, usually with several examples of it. And we found that it only works for specific triggers. The sound of my husband chewing, the sound of my brother or sister, sniffing. As long as they think of those, then it can bring it down. And we've had some good success. It doesn't work for everyone. And you can also have, playing video games. They can be playing video games while they have it. They can be watching videos. The app has the ability to either play music or to turn that off. There's actually 3 different ones. There's the Misophonia Trigger Tamer for iPhone and Android, and this is a dark blue icon. It looks the same with the light blue icon, which is basically Misophonia Trigger Tamer Lite, which is free for the first 14 days. You can run it as a Java program on a Mac or a PC, and the visual Trigger Tamer has a video image that shows, and that's available only on Android. So again, this intermittently presents a reduced trigger when you're in a positive context. So I've got some cases here. I'm going to watch the time. We're going to end maybe at 6 o'clock, but definitely by the end of the 2 hours, and have time for question and after that. We may end a little bit before that if this goes well. So this is a case using the first counterconditioning treatment, the neural repatterning technique, before there was any trigger tamer. Had a 48-year-old woman. She had triggers from her husband, eating bread, sorbet, scratching his beard, and the visual of that. She was overwhelmed by the extreme emotions with repeated trigger stimuli, and she felt she had to stay there. She was having anger, hatred, resentment, rage. And she said it felt like a shovel was run through her sternum and out her back. And we figured that we didn't understand the physical reflex while we were doing this. Probably would have helped if we had. But essentially, it was like closing off her windpipe and then gasping for breath. And if you close off your nose, close your mouth, and try to quickly pull in, you'll feel it. You'll feel a punch right here in your sternum. And her shoulders would come forward and her face would squint. And those were all the things that she was doing when she developed misophonia. Onset was about 7 years. Her brother was her first trigger. Really only triggered by, she was only triggered by family members, so no impact on her social life. She had depression, but that was gone. But she was generally anxious. And again, she had asthma from 4 to early teens and had the same behavior when triggered as she had trying to breathe when she had asthma. Looking at her ratings, we used a misophonia assessment questionnaire by Dr. Marcia Johnson, a misophonia trigger severity scale, looking at how strong individual triggers were, and then the outward responses. We did a weekly session by video chat, which was 50 minutes. 30 minutes of that was this counter-conditioning, the treatment. She'd be listening to, and then she would listen to the sessions, the recordings, or music with the triggers in the week following. At first, we talked about positive life experiences, things that made her, her endorphins run good, and here just a little bit of triggers, and we were quite pleased at the drop off in it. Again, she listened to the audio recordings of that, 4 or 5 times a week, and then we would meet again the next week. And there was a trigger management plan implemented, which basically was do not endure misophonia distress. If you're gonna stay there and endure it and then leave, just go ahead and leave to start with. Don't endure it. Come back when you can. Okay, so at first, these kind of sessions, we did a 5-second soft trigger and use the volume of the trigger to adjust it every minute. She was talking about very positive life events. We want to keep a rating in the 1 to 2 range on a scale of 0 to 5. And again, first session, she heard the trigger 27 times. Then she had her homework. And we moved through the first 3 auditory triggers. And then with the 4th one, I actually started moving my hand up to my face as the trigger. And this is the severity outcome, trigger severity. The eating bread dropped down quickly in 2 weeks. The eating sorbet and scratching the beard were treated next, 2 weeks each. I didn't do a measure at the end of the 4th week. I should have. And then we took the visual of scratching the beard and it came on down. And then we did a 4-month and a 10-month follow-up on those. The eating bread totally went away. Sorbet was, kind of floated back up a little bit. Scratching the beard was going down. Here is her misophonia severity rating. Huge impact from just getting some effect of being able to walk away from triggers and knowing that there was some hope, getting that first eating bread trigger down, which was the most common. And when I talked to her at a 5-year follow-up, she said, I can't remember the last time I was triggered. That was great. So this really supports the theory that of this initial physical reflex, that she had this very strong muscle response in her breath response with the pain. And in the sessions, she reported feeling the physical response without the emotions. And this is not the only person who has, in a treatment setting, feels the physical flinch, but no emotion. So it really, I think, supports that misophonia has this initial learned physical response as a critical feature. Next case is with a young lady we call Miley. Miley was self-diagnosed with misophonia, no past or present comorbid conditions. She was at the university, and the kids yawning were driving her nuts. She was having very severe misophonia. At the university, she was home for the summer. Mom didn't yawn around her, but the mom's chewing and the scraping of utensils and the dishes was really bad. Extreme emotions, onset was 6 or 7, and mom's yawning and gum chewing were the first triggers. And she was sensitive to her mom's emotion, as her mother was often stressed. So her misophonia assessment questionnaire was a 49. Her trigger severity rating was about an 8. Overt responses, we have those, but didn't really do much with that. And emotions. And we tested for the initial physical reflex, and it was a fist clench. So after determining that, we worked on a treatment plan, decided to use the neural repatterning technique with the Trigger Tamer app, which was completed by that time. And the reason I did the app is because it took so much time to try to make the homework files for that first client. And so the recommendation was to add noise to reduce the trigger response in her life, limit her exposure to the triggers, do muscle relaxation practice twice a day, download and learn to use the app, and set up a playlist and a recording of her triggers. And so at the first week, we set it up. We got her trying to do it. She reported that she had been doing the muscle relaxation practice. She was relaxing her hands in public and found that reduced her emotional response. She's adding noise to the home, said that helped. And then we did a short session with the spoon on the bowl, and I turned her loose. And the plan was for her to do the Trigger Tamer daily and the muscle relaxation practice daily. So at the second meeting, she reported she had only done the Trigger Tamer 3 times and stopped because she wasn't triggering. So we worked with her to set up some new triggers. She was doing the muscle relaxation every day. She was practicing relaxing. And the third session was 14 days later. She had done the muscle relaxation practice most days, and she was not responding to any of the recorded triggers, and she was relaxing in real life her hands, and she was feeling the response, but with her hand relaxation, that it was much better, and her difficulty had come way down. So here's her rating. Pre-treatment 49, post-treatment looks like that was about a 12 or 13. 6-month follow-up, she was down under 10, and at 12 months she had developed generalized anxiety disorder, and her misophonia severity was coming up a bit. So I think the major issue with this was that she was relaxing her hands, and when she went back to university on things like yawning, she would relax her hands, she would shake her hands a little bit if she needed to, and it really transferred to reducing the misophonia in the real life settings when she was relaxing her hands. Again, very strong physical response, and relaxing that physical response supported the fact that initial physical reflex, that this part right here, is an important part of misophonia. Okay, another one here I'm going to talk about is John. This was done primarily with muscle relaxation practice, and no threat, but thank you. And so he would typically leave the room after trying to tolerate it. Sometimes he'd leave immediately. He had strong emotions, rage, escape, resentment. So they'd have a verbal outburst. Triggers were chewing, sniffing, adjusting their glasses, and others. He had never had misophonia until he was deployment in Afghanistan, and he had PTSD. And I think this may be a notable issue here. He had PTSD, and so he wasn't sleeping very well. His physical reflex was the head jerk to the right and the muscle tense. Yeah. And so the treatment was muscle relaxation training, and then relaxing the muscles before triggers, after triggers to reduce the anger, and before triggers to try to reduce the response. He was going to use the no threat, but thank you. And he said he really liked that, helped a lot. And then he would move away when he needed to. So after 6 weeks, his misophonia assessment questionnaire had dropped from 38 to 8. and the strength of the individual triggers had dropped from 9 to 6, and I don't have it listed. I think maybe that was for it was still there though, right? And at 7 months treatment, after treatment, he said, I haven't been triggered in the last month. So that was a very good situation. Now here's one of the little fun cases where the child is doing an activity. This is purely experiential. This is a pure behaviorist intervention. There's no psychological component to this. The boy was a 10-year-old, high-functioning autism. He was homeschooled because his misophonia was so bad. He was in virtual isolation, and his triggers were very pervasive in his world. So he triggered to the non-spoken yes and no, which is a low to high, mm-hmm, mm-mm. And those were his two triggers. And so we had he said something he liked to do was bounce on a hopper ball, so we're going to use that. Use the trigger tamer to deliver the recording of the trigger. This is a remote work, so I'm not there. I can't go in and collect the data. Can always be part of it. Dad's going to be running this treatment, but we needed feedback from the child. So you need to know that the child hears the trigger, and then you also need to know that they're not getting angry. Because if they're hearing the trigger and getting angry, that's not going to work. But if they're not hearing the trigger, that's not going to work either. So with him bouncing on the hopper ball, he's making noise. So we tried to find a spot for this, and Dad couldn't find he said, if I get it loud enough so that he hears it and he asks for the little piece of candy, he says, getting angry, getting mad. So Dad and I were going to work on this in a session by video chat. And as we were working on it, something very amazing happened. The boy saw himself on the computer screen. He was enthralled with the fact he could actually see himself. And that became fun. That became exciting. And he was no longer having any anger response when he heard the trigger, even a strong trigger. And Dad could run that for about 5 minutes a day for 30 days, and he virtually stopped triggering. Now, Dad, I kept asking for him to send me the data. It's saved in the trigger tamer. Just hit the send button and email it to me. He didn't, and then the hurricane destroyed the phone. History was lost. So, but at 9 months, the follow-up, the dad said that the child was rarely triggered except by a deep voice. So he's regularly triggered by his grandfather, and there gave an overly optimistic emotional and physical rating responses of 0. Don't think that was real. Misophonia assessment questionnaire of 9, so it's not gone. But he did say, well, my son Matthias couldn't go to school anymore, play with the other kids, cousins, or parents. His triggers were so strong that at a time he told us that it was so hard for him that he wanted to cut his ears. What a change. Matthias, after such a long time, had a great Christmas time with his cousins and family. Now he can play, share time with us and his friends. But at 12 months, his triggers were strengthening. And this is a case where, because it went from high to not a big deal and was left there, then it was able to, through natural exposure, slowly come back up. So I'm going to end with some treatments that people tried that we maybe should think about, but not really supported. So someone somewhere has been cured by almost every possible thing you can think of. Diet, supplements, any kind of treatment has cured somebody. One person that I know cured himself of his misophonia by changing the meaning. So crunching was walking in snow, and he says, now when I hear the sound, I think, oh yeah, I used to not like that sound. So that's extraordinarily unusual. So with EMDR, very few, if any, reports of benefit. Some people will help, but not really a benefit. Neurofeedback, there are some very famous cure reports, but these are people who had over 100 sessions. Most people have no effect from it. One of the things that neurofeedback might be considered for is that it can improve overall health. Get better sleep, less anxiety, less stress. And if I'm bringing down my level of stress, I'm bringing down my level of misophonia. I'm bringing up my health and well-being. I'm bringing down my misophonia, and that can tend to make it go away. Traditional hypnotherapy, that is not typically helpful for misophonia. Either no effect or only a short-term effect, like maybe a month. Typical talk therapy that's not misophonia focused is of little help. And medication for anxiety, depression, sometimes that may help, but only really if you have anxiety problem or a depression problem. Now, the one thing I realized I didn't include in here is other comorbid conditions, PANS or PANDAS or Lyme disease. I did mention like intolerance. If you're in Virginia and going up the North Coast, there's the Lone Star tick that carries a something that gives you an allergy to red meat, and 25% of the people in Virginia have that allergy. So anything which compromises a person's health and well-being, any health problem should be ruled out, especially in children. So I think what I'm going to find next is kind of my conclusion here. I think we have good reasons for hope for people with misophonia. So as a misophonia sufferer or someone who loves someone with misophonia, there's reasons for hope. First off, the research is increasing. We're really gaining an understanding of misophonia, what it really is, how it develops, some of the things, ways to get rid of it. Several treatments are showing benefit for many or even most people with misophonia. We have made great gains in misophonia in the past 6 years. And hopefully, in the next 6 years, are going to be even better for misophonia sufferers. So in my opinion, for most people, misophonia does not have to be a life sentence of suffering. So have hope, get help, and don't give up. And as they say on Galaxy Quest, never give up, never surrender. So thank you very much. I'm Tom Dozier, and it's been a pleasure to present this webinar to you. And now we're going to open the chat box. I got to find it. Where's my chat box? I got to be careful here. I just opened something that it's trying to close my whole system. If I click on it, I do not want to shut down the webinar. Okay, so where is my chat box? There it is. Okay, folks, let's go look at let's pull the chat box out here, and let's see what kind of questions we have. I'm going to start at the top. Go ahead and type in any questions. So Laura, you said, is there any evidence that SSRIs or SNRIs actually lessen the misophonia itself? Is there any relation? So I hope I answered that by saying if you improve your health and well-being, you will often lower your severity of your misophonia. You may still have the triggers as strong, but you can handle them better. So there's no actual indication that SSRIs change these inherent reflexes. If you look at the research that Dr. Kumar did, it shows that there's an extreme increase in myelination up in the AIC and the VMPFC and the hippocampus and amygdala, and that these are strongly connected emotional reflex responses. So this is the same neurology that makes you like your mother's voice as a baby. So no, there's no evidence that there's a relation of changing the actual misophonia reflex, but some people, again, benefit from it. In fact, some people have benefited from ADHD medication. So what should the kids do in school when they can't avoid triggers in class? Well, they can wear headphones. They can wear, they can wear an earbud, and with the earbud, you can play your noise, so you can add noise to the world. You can have the classroom with noise in the classroom, and all of those things are very powerful and beneficial. And you can have a place that when a child is being triggered too much, that they can leave and go to without permission. They may have to hold up a card, they may have to put something on their desk, they may take the little pass out with them, but they should be able to do that without permission. Okay, I had a small throat clear there, I apologize. Next question. Are we supposed to be able to see you? Yeah, you are, and we're recording it. So sorry about that, Debbie. Hopefully you found the little window that had me in it. Okay, when looking for a treatment provider, what credentials should we ask for? How do we know they are qualified? Valerie, that's a very good question. I would ask, do you have experience in misophonia? How many people with misophonia have you treated, and what kind of outcomes have you had? It's a definite issue because we have a great lack of people that are qualified to treat, and there's no one discipline that's included or excluded. So that's a tough one. Okay, let's see what else we have here. Okay, got that one. So any comorbidity with alcoholism? I'm sure there is comorbidity. There are people I know that have gotten sober because they used alcohol to squelch their misophonia. So I don't have any particular data on that. But there's a lot of comorbidity with a lot of other conditions. Okay, if you use the thank you technique, this is from Marge. If you use the thank you technique, how can you use this when you're in public? Okay, that's a very good question, because Marge, you don't have to say it out loud. Okay, if you're in public, you think. Okay, you just think it really, really strongly with gusto. Thank you, and smile. Yeah, you don't say that out loud in public. Okay, from Laura, how is the Trigger Tamer app listening to triggers in a controlled way different than exposure therapy? Well, it is a form of exposure therapy, okay, but it is exposure. It's well done exposure therapy. So it's not sit here while I eat my chips, because real world exposure increases severity, but limited exposure of mild triggers in a controlled situation where you can relax, or where you're happy playing a video game or doing something fun. Or as one woman did, she would had her smartphone and she was looking at pictures of her dog, and her dog made her thrilled, it made her soul filled with joy, and that was a positive stimulus, and the triggers just faded away. So the Trigger Tamer lets you control it, mute it down, modify the trigger to the level that on a scale of 1 to 10, you're having a 2, right? You're not having an 8 or a 6 or a 9, you're having a 2. And you want to have a positive, happy, and if that's too much for you, have 1. You want to have a positive, happy situation that can overwhelm that trigger. So the Trigger Tamer has gotten a lot of people complaining that it's exposure therapy, it's dangerous, it's horrible. But you need to have some experience with triggers to make the reflexes, the emotional and the physical reflex, go away. Even Sequent Repatterning hypnotherapy, which never exposes a person to a trigger, uses the memory of the trigger. Okay, so essentially auditory hallucinations. And Jolene Jaffe, Dr. Jaffe says, oh, I never expose them to triggers. Yeah, but you teach them how to go back into the real world and have the exposure in the real world where they're calm and they're relaxed. And again, that's a form of exposure therapy. So it takes, in most of these treatments, it takes, unless you're overcoming some, medical, physiological, neurological damage deficit, it's going to take some experience with the triggers to bring that down. Anyway, so that's the trigger tamer, lets you really bring it down and control that. And you're in charge, so you only do it when you're happy. I've had a person who was doing muscle relaxation, and so the wife was a trigger, and he said, well, I have the wife do the triggers, and then after a while I'll say, oh no, that's too much, I've got to stop. I said, well, don't do that, right? Don't go that far. Have her do the triggers for 15 seconds and then say thank you, give her a hug and walk away, right? Bring all your positiveness and your composure and your happiness. And by the way, this guy had gone from up here on his misophonia down to here, and he's just working on the last little bit. He never would have done this to start with. And it's only because he's become so good at muscle relaxation that he decided he wanted to address this with his wife. But again, you need to keep it small and pleasant and positive. Okay. Next question here from Marge. If you're triggered by some noise a partner, etc., makes, can you just ask them politely to not do this? Well, but Marge, a lot of the things that we have that are sounds, that are triggers, are just natural sounds in the world, right? These are just the sounds of life. There's nothing inherently evil about these sounds that become triggers to us. We just started reacting to them. And, one of the things that Dr. Jaffe wants people to do is to give up being the etiquette police or the morality police, right? This is not for us to decide what's good and bad and be irritated by it. So, yeah, of course, you're welcome to ask a partner to not do that if it is reasonable. But when an 8-year-old turns to their mother and says, stop breathing, it's just a sound. So it's just a normal sound. So, by the way, if anybody has breath-related triggers, bringing up that background noise makes an enormous difference, right? Do that. Makes an enormous difference. Okay. Why does mimicking a trigger help me get through the angst? Good question, Kimberly. I'll give you some opinions. I don't have any research or facts, but here's some things that people said. Well, first off, if you're mimicking the trigger, it may be a way of saying, listen to how disgusting you are, trigger, right? Listen to how ugly it is. Don't you see how horrible this is? So it's a way of kind of fighting back at the person. Like, I will show you how disgusting you are. The second thing is that if you are making the sound while the person is making the sound, right? It's not they make it, you make it. They make it, you make it. That's just telling them how ugly they are. If it's they're making it, so you're eating, you're making the sound, then that is a way of you can't tickle yourself, right? So it's really rare that people trigger themselves. So if you're making the sound, you're hearing your sound, it's great masking. By the way, corn nuts, if you trigger to crunchy sounds, Marsha Johnson said, keep a pack of corn nuts in your purse or your backpack. Have your dark glasses to put on to stop the visual triggers. Be prepared to handle these situations. But corn nuts really are allowed. And if you're eating corn nuts, you're not going to be triggered by anybody else making crunchy sounds. So that's there. Okay, question here from Barbara. For a 10-year-old girl who has had some minor symptoms for several years, not sure how long, but at times are getting debilitating, where would you begin? She experiences days without triggers, but outbreaks are getting more frequent. Want to treat it immediately to try to keep from getting worse and her to get her relief. Okay, so one of the things that I do is I do an assessment, education, management, treatment option session. Really helps to figure out where the misophonia is, where to go. Now, Barbara, you're saying she goes days without it, but my guess is, I don't know, my guess is she's experiencing some triggers and she's stuffing it, right? And then some days they blow up. So parents will say, why does my kid trigger and yell and scream at me when they're by, when they're here by themselves, but when their friends are here, they're not triggered? Well, the answer is they are triggered when their friends are there. It's just too embarrassing and socially damaging to scream and yell when in front of your friends. So they just stuff it. So that's one thing that would come in the assessment. The second thing, this girl's a 10-year-old. If she's having ups and downs over days, my guess is there are also emotional stressors that are going on here. It could be siblings, it could be conflict, it could be stress with whatever her demands on her are, or it could be even just family dynamics and such. And the parent coaching that I do will make a big difference if there's those kind of stressors, because I have ways as a behavioral parenting coach, and that's why I got into this. I'm originally an engineer for 30 years, and I got into behavioral parent coaching because a great man who was a behaviorist helped me through my struggles, and I wanted to help others. So the behavioral parent coaching will definitely be something if there are any cooperation dynamic issues there. But anyway, I work by video chat, and that's a place to start. And then if the hypnotherapy is advised, we go that direction. If games are advised, we go that direction. If the family stress is there, we do the parent coaching and maybe hypnotherapy at the same time. So those are, and maybe some of it's just good management. Maybe you could just have enough noise in the home to bring the edge off of it, and then try to have, bring it down that way. So again, I do work with individuals with this kind of situation. It would be a good place to start, and I can help you get the help you need. Okay, from Mark, do you think there's a reason meso reactions are so strong between primary attachment relationships, kid to parent, or between intimate partners, other than the fact that there is just more time spent together? Well, two things. Yeah, more time spent together means a lot more examples of triggers, and it's not just the time. You get into situations where you can't just leave. If you're having a trigger at work and you're in a meeting, it's going to go for no more than an hour. If you're having a family holiday at your parents' house, you're going to have to deal with them for maybe a 4-day weekend, right? Or at least all day. And so it's both the total number of triggers, and it's also the opportunities that there's a stressful situation. For some reason, I'm stressed, I'm tired, and now I'm there with the trigger person. And again, strengthens the ventromedial prefrontal cortex, strengthens the amygdala and the anterior insula, and strengthens the physical reflex, and boom, you're just going crazy. So but there can be some times that if there's, I'll tell you a good one, parent-child conflict, right? The parent uses normal parenting skills. This is with the child, like, okay, you got to do your homework, and I'm going to stand here until you get it done. Or, like I said, it's time to turn off that computer, turn it off. Those kind of methods, normal methods, generate anxiety and stress and pushback. And again, now there's anxiety and stress and pushback, and now it's gonna fuel the triggers. So by the way, about turning off laptops and battles with laptops, if any of you have experience with that, I need a couple of people that use IBM PCs and or laptops with a remote shutdown program that I'm just having written. I could use your help testing it. Send me an email and I'll share it with you for free, and you can be a tester for that. But that's one of those cases where the kid says, you say, it's time to turn off the laptop, Joe. And Joe says, oh, 5 minutes. Okay, just a minute. You come back 10 minutes later. Joe, I said, turn off the laptop. No. I got to finish this first. And that kind of conflict will drive the misophonia also. Okay, from Valerie. If the provider we find uses one of the less effective methods, is it worth the time and investment? Is misophonia recognized by the health insurance and coverage? Well, so first off, you can call misophonia something like abnormal audio perception as an audiologist and get some coverage with that. You can call it anxiety disorder not otherwise specified or something like that and get a therapist. I would say you have just as much chance of making your misophonia worse if you go with someone who doesn't understand misophonia than making it better. So I think it's a waste of time. If you have someone that you want to work with, ask them to get some training on misophonia. Misophonia Institute has training. Even just watching this webinar to get a concept of what misophonia is would drastically increase the chance of someone, a therapist, helping you. Okay, so I would not go to a therapist who doesn't know what misophonia is just because it's cheap or free. Tom's opinion, right? Find somebody who knows about it. Contact Jolene Jaffe. She works by video chat, but insurance would not cover her. Okay, unless you're in California. How do you go about choosing a treatment to start with? Okay, Philip. So that's one. I mean, some people have their personal preferences, but that's one of the reasons I do an assessment, education, management, and treatment options. Some people find with the assessment that their physical reflex can be addressed directly, and they're going to go try that for a couple of weeks. Other people, no, we're going to go straight to hypnotherapy. But right now, the best treatments that I know of, and I am prejudiced, okay, so bias included, is to start with me, and then if it's very severe, go with the Sequent Repatterning hypnotherapy, and then come back for the physical reflex, the interactional work with me. We had one individual who did Sequent Repatterning hypnotherapy, and after the emotions were all gone. I mean, Chris Pearson did this, not me. And so it'd be like, before it'd be like sniff, ah, sniff, ah, okay, and after it's sniff, ah, sniff, ah. And like he was getting tasered, but he can't, the emotions were not there. Well, we did the trigger tamer with him, and he was getting tasered everywhere. And this is the one time we've had an everywhere response, because we could use the trigger tamer stronger because there was no emotions to be triggered, and the physical response, the body taser response, went away, and his misophonia is gone. Right? It's completely gone. So my recommendation, when somebody doesn't have someone they want to work with and someplace to go, start with me with the assessment, management, education, treatment options. Then you choose a path. You either go the behavioral path, you go the hypnotherapy path. You may also do they're compatible. You can do them both at the same time. And if there's any stress with children and things, you work on eliminating the stress with the children also. Okay, let's see. Next one from Mark. For adults, I see a big role for complementary couples therapy specific to miso. The interreactivity can get quite complex and can add other layers of problems. What are your thoughts on this? Yeah, I would love for therapists who know about misophonia to work on that. But I would also want the person with the misophonia to work on trying to bring down their reflex and to add the noise to the background to, if their person triggers to fidgeting feet, then if you're going to watch TV together, the person with misophonia is slightly ahead so they can't see the feet. You do things to make it more livable, because the response for misophonia, and I'm not sure, Mark, I'd almost guess that you may not have misophonia, that your loved one does, because the response of misophonia is so overwhelming that it's just almost impossible to pull make that nice without some good management. So if you do the interactive couples therapy, I think you also need to start with the assessment management education options to or really work that yourself if that's what you want to, but really work on that to try to make life very pleasant and positive and working together. Okay, question here. Do you anticipate new Trigger Tamer apps or improvements? So right now, the new Trigger Tamer app was the light blue, which is free for 14 days, so people don't have to spend their money on the one that is the paid version, which is $39.95. Well, that's good for you, but I get no revenue from it. So that was, I don't know, $1,500, $2,000 or something, maybe more, $1,500 plus my time of working it with no revenue from it. So unless there is a demand, I don't see improvements in the Trigger Tamer apps. There's things we could do if there was a demand, a pull, and a revenue stream, or maybe we could crowdfund it. Hey, I would be glad to crowdfund improvements to the Trigger Tamer app if we had people who thought they would want to do that, to like do multiple triggers at the same time. Anyway, that's so sorry about that, Debbie. Okay, Melissa, does anyone see improvement if they also have visual response to a trigger? Well, by visual response to trigger, I think what you're saying is a visual trigger. And my work with triggers, so for example, the lady who triggered to the bread chewing, the sorbet eating, the beard scratching, and the visual of the beard, once the sound of the beard scratching came down, the visual was completely unaffected. So the visual, once a stimulus becomes a trigger, it creates its own response. It doesn't have to be paired with auditory. That's my experience. So I think maybe if the auditory came down and you could look away, you could relax, you could have a lower response, you might be able to work it down. But I don't see that taking out a visual trigger takes out an auditory trigger. Will you be posting the presentation and recordings on your website? Yes and no, Michael. What I'm going to do is I'm going to upload it to YouTube to a non-published link, or you'll have to go to training to get it. But everyone who signed up for this webinar will have access to the video, and quite frankly, the Misophonia Institute needs the funds. So I'm going to see if I can use this as a fund generator for Misophonia Institute. It costs us about $1,400 a year to have this capability of presenting this. So eventually it will be published on Misophonia Institute and on the YouTube channel. Okay, so let's see, from Laura. Why does context affect the reaction so much? Ooh, that is such a good question. An older dog licking bothers my daughter, but a cute puppy doesn't, even if the sound is the same. Same is true with friends at school. She can tolerate eating from them, but never the parents at home. Does this imply that the child has choice of whether the trigger based on the context? No, it's not choice. So here's an example. If you've seen the old MGM movies, right? The lion roars at the start of the movie, right? And you say, they go, hey, the movie's going to start. Trooper. Okay, close your eyes. Imagine you're in a forest, in a tent. It's 2 o'clock in the morning. It's silent, and you hear, are you going to freak out? Well, sure you are, but it's the same auditory stimulus. So what's called a conditioned stimulus, that's the technical word for a stimulus which causes the learned or acquired reflex, is a complex stimulus. It includes the stimulus, the context, the social setting, the expectations, who's there, color of the room. So all of those things go together. And it may be that the cute puppy is so fun and happy and she hasn't developed it to that. When I first started, there may also be subtle sound differences. When I first started, the first person I ever worked with misophonia, I didn't, I thought it was it's a reflex condition. I didn't know anything about the physical response. We're going to do a little test here. We had him face the wall, took 2 free toes the size of my thumbnail. I put one in my mouth, went crunch. He goes, no, that's nothing. I only triggered my mom. Mom puts one in his mouth, her mouth, it goes crunch. And she goes, oh, that's it. So he could tell the difference. His lizard brain could tell the sound difference. And a puppy doesn't sound the same as an older dog. That's one. The second, context. She has, puppies are fun. I'm having fun with this little dog. And where the older dog doesn't cause the fun, and therefore context is different with the puppy. With home, I mentioned that before about home having so many more examples of triggers that you strengthen the reflex, right? Oh, I'm at home, it's going to be a trigger. I'm coming home, I'm going to have to do homework. Now I'm more sensitive to triggers. I'm coming home, there's my brother here, he's going to bug me. Now I'm more sensitive to triggers. So there's both context and experience. It is not a choice. I have never known a situation where a child could simply turn on and turn off triggers in certain contexts. Now, they can turn off whether they yell or not. They can turn on and turn off, whether they go running and screaming out of the room or they push and hit somebody. That's different. But in terms of whether they're triggered or not, that's not a choice. Okay, in my opinion. But I think it's an accurate one. Okay. Hi, Tom. Thank you for the presentation. I'm interested in seeking treatment. Are you able to share any information on pricing of your services? I don't think that's really appropriate here. Anybody that's interested, send me an email. I'm happy to respond. If I don't respond within 48 hours, something went wrong. I lost it. I misplaced something. But all of my emails goes into one big bucket, and I'll see it no matter what email address you send it to. And so there's one on the screen right there, tdozier@misophoniainstitute.org. It goes into the same one that that everything else goes into. So yeah, Agnes, I would happy to let you know about that. Anybody who wants to know, it's not secret. It's on my misophoniatreatment.com website. So misophoniatreatment.com is my commercial website for me and trying to share other information about treatment and other treatment providers. Misophonia Institute is our 501c3 nonprofit public benefit corporation, and we try to put general information about misophonia there that can help everyone, not solicitation of services. So, okay, it looks like we've run down. We're 23 minutes. I said a maximum of 30. We have a great number of people who've stuck with us. So I'll give you till a count of 10 to ask another question. I will say that misophonia has been very surprising to me. I've been accused of trying to fit misophonia into my behaviorist box, but quite frankly, I went looking for misophonia thinking it was just this emotional problem and looking for a way of understanding the reflex and helping, and I'm where I found it. We followed the leads, and we are where we are. So Valerie, you're welcome. She says, thank you very much. Very good, helpful. You're a terrific resource. So everyone, thank you very much. I will let you know as soon as we get this uploaded and recorded so that you can watch it. So I'm going to say thanks very much, and I wish you well.